we'll move to the next presentation, and the title will be The Role of ID Clinical Pharmacist in the Round. And the speaker is Mr. Mark Gilchrist. He's a consultant pharmacist, infectious disease at the Imperial College Healthcare NHS Trust, UK.
Thank you to the organisers for the kind invitation to speak. I know we're limited on time, so I'm going to be going over some of the slides quite quickly. I think they'll be available at the end of the session if you want to ask any more questions. But this will be a speedy tour. So what I'm going to talk to you about is really the changing patterns in medicine use initially, and then going on to the value of having a pharmacist within the team, the stewardship concept within my own institution within Imperial in London, to give you a flavour of how that works, and then the specific roles of the ID and clinical pharmacist on the ground. And I'm quite conscious that in a lot of organisations we don't always have ID trained pharmacists, so this is applicable to the clinical pharmacy teams, or how you upskill your clinical pharmacy teams on the ground. So as we know it, medicines are one of the largest interventions in healthcare. We spend, or last year we spent on average $1 trillion on medicines use. That's set to rise by 2017 to 1.2 trillion, and with an aging population and growing diagnostics, we're making patients sort of live longer, we're giving them transplantation. They are more complex, and with complexity becomes new medicines and polypharmacy, and that's really where one of the roles of your pharmacist on the round comes into play. There are, as we know from this conference, a major AMR threat. There are less antibiotics available, and we're having to go back to sort of 10, 15, 20 years ago of using older antibiotics where the trial data wasn't as robust as it is now, or wasn't as rigorous for the complexity of our patients. That, coupled with the error rates that we're seeing in hospitals with prescriptions. So on average we have approximately 50% of our IV doses that are given in hospitals. From the global literature, there's some sort of prescribing error with those. 5% of our admissions to hospitals are linked to an adverse event through some shape or form, and also within infection in general, we think that C. difficile can be associated with the inappropriate use of antibiotics, and that's led, particularly in the United Kingdom, to outcries within the press about prescribing rates. So we've seen a cultural shift within the relationships within healthcare professionals, the patient changing, and really all the disciplines coming together within the AMR strategy to fight against resistance, but also do the best for our patients. If you look at the literature in terms of pharmacists on the round, there's a number of papers, and I appreciate the screen's small that you won't be able to read the minutiae here, but actually if you look at the data around having a pharmacist on your round, you'll look at the positive impact. It's around reducing adverse drug events, optimizing doses, reducing the chance of error, and that's at the point of prescribing. That was in 2003, and over the years you can look at the literature. 2005 and 6, this was a paper that was done in the United Kingdom and teaching hospitals in London, looking at the point of admission. So what do pharmacists do at the point of admission to help minimize the threat of AMR, but also reducing adverse events? And again, the minutiae of that you can read in your handouts, but you'll see there that the interventions were around reducing the frequency of drugs, reducing duplication, and avoiding error. And really that's where pharmacist interventions are based. They're based around resolving prescribing errors. They're based around making them as soon as possible, and preferably at the point of prescribing. A lot of adverse events are preventable, and it's been suggested that if you don't have a pharmacist on your round, you sometimes don't have the information to be able to deliver a service as best as you could be. There are data in terms of consultant-led rounds. Again, this was done within an Imperial in terms of looking at the availability of dosing structures, looking at the frequency and duration, as well as deletion of therapy. We know that within our own organisation, 40% of patients are on antibiotics at one time. So if you take these figures and take 40% of them, they're applicable to antibiotic therapy in general. In terms of the AMR strategy, there's 3 key documents that quote pharmacists' value in terms of ward rounds. The IDSA guidelines have been around for many years. The Australian guidelines came out in 2011, and also the UK practice guidelines for AMR and antibiotic use within the United Kingdom all quote the value of the MDT team. And again, you'll see the HCAI diagram talked about in the next couple of days in the workshops, but those in red are really the key areas that pharmacists can make an impact on. And again, we're starting to see the literature come through at conference settings, and this was presented in 2014 at ICAC from a Thailand group in terms of interventions they make on stewardship. So the evidence is there, and I'll give you a little bit of background from my side. So I'm from Imperial College London. We're a large teaching hospital in the west of London with over 1,000 beds, 4 divisions across 4 sites. We cater for multiple trauma care and had a very diverse population. And our stewardship program has really been sort of embryonic in nature in terms of that we moved 2 trusts to 1. We created a larger stewardship program, and this is how it operates. Sorry, I don't have a point. I do have a pointer. We have a core team in the blue squares, which is ID physician, pharmacy and microbiology led, so we all have equal playing fields. We work with our divisions to deliver our stewardship program, and we work with the various committees in the hospital and at board level to deliver the key performance indicators around stewardship. Excuse me. We know that approximately 40%, as I've said, of patients are on antibiotics at any one time, but we only have 2 to 3 infection pharmacists working on the ground. So we utilize our pharmacists within all of these disciplines that are on the screen. So we have pharmacists on ward rounds in all of these specialties. But where we have the most work is within the admissions unit, because those are the patients who come into the hospital, and within our critical care units, because those are the places where we breed multi-drug resistant organisms. We do have policies and procedures in place, but actually we're turning our attention now to a more tailored individual therapy rather than just going by policy. And that, I can't go back. Okay, we're skipping slides. So this was taken on Friday just to illustrate the point. It's ID physician, one of our trainees, and also we had a pharmacist from France on our ward round. We have 4 main domains. We look at clinical aspects, patient safety, education and training, and governance and safety. And so we go with the mantra that actually our antibiotics don't have the right doses. We work on the premise that patients have right doses, and on that theory we optimize and tailor therapy. Dose optimization, as I've spoken about, looks at PK/PD principles. It looks at formulation choice, the speed of delivery, whether we give things IV or orally, bone penetration and obesity. Now it depends what specialty you're in, but this gives you a flavor. Dose optimization is key, whether or not you're looking at the GI tract, the liver, metabolism or renal insufficiency. And really what we're after is a PK/PD relationship to get as much drug into the patient with an effect and outcome as best as possible. These are really to illustrate the point, and these were taken on my ward round on Friday. Is if you look at the top here shows somebody with urosepsis who was prescribed tazocin, then gets given meropenem because the ward round or the team at the time thought that escalating to meropenem was better because it was the better drug, but actually the dosing structure was completely wrong. And so we came along on the round and gave a loading dose and educated the team about prescribing meropenem at suitable doses to avoid resistance and actual therapeutic value. And again, we have the same thing happening with our pharmacists and teams working independently on the ground. Pharmacists recognize that the creatinine drops and communicates that with the team, but the team doesn't change the dose of meropenem until 3 days later. So being there at the point of prescribing makes a huge difference to our actual use of antibiotics and appropriateness. Knowing about IV to oral switching, knowing about whether or not we give something centrally or peripherally is important. Continuous infusions are coming much more to the frontline medicine use in terms of antibiotics, so continuous infusions of benzyl penicillin for group B strep, for vancomycin infusions, etc. And again, you'll see the literature talking about the debate. Do you use, in your own practice, what I would challenge you, do you use tazocin infusions? Do you use beta-lactam infusions? Do you only limit them to your critical care units, or do you use them elsewhere? And you're seeing this coming through in the literature. Within ITU, we've got meropenem, and now we've got high-dosing colistin being used. And really, the role of the pharmacist on the round is to hold people's hand in a way and make sure that people can prescribe these and have the knowledge and the evidence behind them to deliver these safely. Knowing about bioavailability and kind of the drug expertise is critical. There's a number of drugs and antibiotics out there, but knowing their bioavailability, first-pass metabolism, half-life is critical. Knowing about tissue distribution factors is important, whether or not you're looking at local circulation. So you're looking at the diabetic foot where the vasculature is not great, or you're looking at a patient with meningitis or some CSF infection. PK/PD principles in terms of the anatomical sites is important, and those are on the screen there, and you can read them in your own time. But for us on the ward rounds in orthopedics, our pharmacists and clinical pharmacists on the ground need to know about bone penetration. They need to know about antibiotics in cement. We use a lot of antibiotics in cement, and getting the right drug in the cement is critical, depending on whether or not you're using a heat-stable antibiotic or not. You don't want the prosthesis to start moving around 2 or 3 days or even a month into therapy. Obesity is a problem that we're encountering more and more in healthcare. How that affects your drug delivery and drug systems is important, and you need to know about those. The dosing structure for those antibiotics is still up for debate. But the doses on the screen are what is best practice at the moment, but it is an ever-changing concept. In terms of looking at efficacy, which I think is probably what pharmacists are best known for on ward rounds, therapeutic drug monitoring is really the mainstay in terms of gentamicin and amikacin, but actually we're moving now to vancomycin continuous infusions, ticaplanin with double the dose that we used to use 2 or 3 years ago, and antifungal assays. So within our own institution, we do antifungal assays on Itra, Vori, and Posa on a regular basis. Daptomycin, we still don't know what the right dose is within our renal population. There's good animal models to suggest a dosing structure for hemodialysis, but we don't really know. And being on the ward round and discussing the holistic approach of the patient can try and optimize that dose. Cycloserine and moxifloxacin we do regular TDM for as well. Understanding if the patients are on dialysis also affects our dosing regimes, and being there at the point of care can optimize the dosing structure. A lot of people I've seen prescribe antibiotics for midday, not realizing the patient actually dialyzes between 9 and 2. And if you do that, the patient doesn't have a drug on board until their next dose, so they're potentially going without any antibiotic therapy. So for that reason, that we always recommend dialysis dosing at 10, 11 o'clock at night, unless you're on this thing, in which case we recommend high dose or continuous infusions of most of our antibiotics to make sure they get a therapeutic level.
2 minutes. 2 minutes.
Thank you. Indications are a nightmare for us as pharmacists, and I think one of the critical reasons we're on around is to make sure we know about why we're using them and the licensing requirements around them. I don't know if any of you have seen within Europe anyway, the Medicines Agency sends out various alerts every couple of years. We've had tazocin alerts, we've had ticaplanin alerts, and most recently colistin alerts telling us how we should standardize best practice across the UK and Europe. And in doing so, if you deviate from that, you're off license and potentially open to, nowadays, more litigation. We look at allergy, efficacy, toxicity, side effects and interactions. Those are bread and butter, but can contribute massively to the adverse drug event criteria. IV to oral switching is also important. For those of you that will be attending the workshops over the next couple of days, we'll be discussing this in a lot more detail in terms of interventions that you can make and measure. In the interest of time, I'll move on slightly. The practicalities of prescribing and logistics is a critical role for pharmacy on the round. Looking at electronic systems, being able to navigate electronic systems. As I grow older, I always get a little bit non-tech savvy, so I always rely on my junior colleagues to tell me how to work things. Bringing things to the attention of pharmacy and the criticality, so making sure your pharmacist on the round knows to deliver that agent or drug in a efficient manner, or liaising with the appropriate people. And also dealing with drug shortages. I was amazed, if you look at the FDA website, they have a website dedicated to drug shortages. And if you look at what's on there, a lot of them are the mainstay drugs that we use in clinical practice. But also if you look at an analysis, and you can't read this hugely, but the dark blue bars on the left there are the number of hospitals and countries that reported how often they have a drug shortage, and the ones on the right tell you, did that impact on clinical care? So the dark blue lines are the ones that say it had a negative impact on clinical care. Policy adherence is critical, as well as promoting best practice, upskilling your workforce, as well as leadership around AMR. All of these things combined are critical roles for pharmacy colleagues. So in summary, providing expertise in terms of advice, liaising with other departments, looking at point of care intervention is critical, but demonstrating leadership as part of the team. And I think it's well recognized now that pharmacies sit as part of that team driving the AMR strategy. There's a YouTube video that will be in your handouts that you can look at, talking about the role of pharmacy in AMR and as part of the round. But on that note, I'll say thank you very much.
Thank you very much, Dr. Gilchrist.